And now I want to introduce Dr. Joe, so don't come in yet because I really haven't started. I really thought about memorizing this, but there's words I can't say very fluently, like pulmonary, but there's other things that are here because doctors have all these crazy things they do. So anyway, Dr. Joe Ojile is the founder and CEO of the Clayton Sleep Institute, which is a sleep medicine, clinical, and research organization. Joe is also president of the Clayton Sleep Research Foundation, which produces an annual national conference every year, and that's on updates in sleep medicine. He serves as clinical professor of the internal medicine for St. Louis U School of Medicine. He serves as National Sleep Foundation Board of Director. He is the chairman of the National Sleep Foundation Subcommittee on Continuing Medical Education. And then he serves as Practice Development Committee for the American Academy of Sleep Institute. So quite a few things that Joe's involved in. All his career, he's managed clinical research studies that focus on sleep disorders, diabetes, pulmonary disease, and regularly lectures on these topics internationally throughout the world. So Dr. Ojile has a lot of certifications as well, and the certifications include the National Board of Medical Examiners, the American Board of Internal Medicine, and the American Board of Pulmonary Disease and Sleep Medicine. Yeah, he got his education in Texas at St. Mary's University, and he also received his doctorate in medicine at St. Louis University here in town. So I'm sure he's going to say that because he's been a member of EO now for 10 years, that he owes us all of the success. So without further ado, Dr. Joe Ojile.
Overly generous introduction. I want to thank the EO, you guys, for coming out this morning. It's always an honor anytime somebody comes to hear you speak. I'm always shocked. I want to thank Jeff Linehan for organizing this, and Jen, and Greensfelder. So our goals today, I want to lay out a few goals for us. This is a talk I really like a lot. And it goes all the way back to St. Mary's. Mike Brennan's here, so we're cohorts from St. Mary's University. It's a talk, if you've ever been to an Italian restaurant, you know, St. Louis, we're big on Italian restaurants. And you walk in, and you'll see on the wall, it'll be a piece of wallpaper, and have like the Roman Colosseum, Leaning Tower of Pisa, Venice, all in one view, right? So this is kind of sleep, all in one view. It's a little condensed. It's designed to give some information. It's designed to stimulate conversation. So part of what we're going to do today is go through this. I'm going to give you some overview, some science, kind of all mixed together. And in order, we're going to touch on lots of subjects quickly. And then we'll have a good chance for doing Q&A. I don't think we lost all of our QA due to technical problems. So I think we can do a lot of that. So I want to get to where you need me to be. This is about us as an organization and me giving you what you guys might be interested in. So I hope that'll lay out okay for you. We had a little video that we're not going to show due to technical reasons, so you can look it up. But I brought a video of humpback whales sleeping, which is kind of cool. So every organism in the world that we know of has to sleep. And so it's kind of neat to see organisms like whales sleeping in the ocean. They sleep kind of up, either up and down, by their tails up or their noses up, and they come to the surface. But the key there is that they need to do it for life. If they don't sleep, they die. And a lot of organisms like whales, birds, things like that, they have one side of their brain that sleeps and the other side of the brain that stays awake. So it was just something fun to start with, and you can look at it another time. Any questions before we get going? Don't bother. If you have something as we go along that you want to ask about anything in particular, throw it out there. This is a small, cool group. We can go from there. In medicine, we do a thing called disclosures. I'm not going to have a disclosure slide. It doesn't apply here, but I don't have anything to disclose. When you're presenting to a science meeting, you have to disclose if you have any financial conflicts with your lecture. So just in case that's an issue for anybody, sometimes it is. So, and my friend Brandon and Jeff Linehan said I had to start getting more social media savvy, so I put this on a slide, even though I'm not even sure what some of these things are. So should you guys at any point want to go to these things and get some regular sleep updates, if you go to Facebook, actually, I've never actually been on Facebook, but you guys probably have. We will regularly put out little tidbits about sleep, updates on the latest science articles, things like that. I think you'll find it enjoyable. So these are just some overview statistics. I tend to wander around, so don't pay attention to that. These are just some overviews of why this is an important topic. So more than 40 million Americans suffer from some type of sleep disorder. That doesn't mean that they have difficulty sleeping. That's 40 million people who have some sort of disorder. More than half of those people with a medical disorder complain that they have poor sleep. And poor sleep, as we're going to talk about, is linked with high risk of both acute and chronic medical disorders. When you look at the statistics, the National Sleep Foundation, every year we do a survey of sleep. It's the most widely quoted poll in the United States. It comes out in March. It's called the Sleep in America poll. So you'll frequently see us get all on the news. Well, they send us out like a little army of soldiers to talk to the media about the poll, and we're interviewed each year. It's very interesting. But about 3 years ago, one of the polls was looking at how many people have some difficulty sleeping during the course of any month or year. 2/3 of our fellow EOers and fellow Americans have difficulty sleeping at some point during the month. So that means it's a common and significant issue. So some of the complications of sleep, this is a nice laundry list. We're going to hit some of these. So I want to give you a little secret about what we're talking about today and why. I gave you some of our goals. But the concept of this particular discussion is that sleep is not viewed as an organ system traditionally. It is my personal point of view, and this is something I've been touting around the country, is that we should look at sleep as an organ system. It functions as one. We're going to talk about that, and it affects every other organ system. So this just gives you some of the complications of sleep, and we're going to hit probably almost all of these during the course of this conversation. So what's an organ? It's a system or group that works together to perform a certain task. Well, I think we meet that criteria. It performs a specific function or group of functions. So sleep may be viewed as a virtual organ, which is why I knew for sure that Brandon, Derek, and Jeff would really like this, because they're all about virtual. Fully integrated with all the other systems. And it's a meta-system, so it's a system of systems. What about diabetes and sleep? So diabetes is one of the most common problems in our country today. Sleep disordered breathing, so people who struggle to breathe at night, they stop breathing, choke, or gasp. Conservatively, about 10% of middle-aged women, 24% of middle-aged men. Now, not many of us in this room fit that criteria, but one would contend that it's a really common problem with those data. BMI, everybody knows what a BMI is here, right? Okay? BMI is over 30 plus diabetes. 60% of those people have sleep disordered breathing. What sleep disordered breathing is, we're going to talk about what obstructive sleep apnea is, but it's altered breathing doesn't quite meet the criteria of being obstructive sleep apnea. About a third of those people have obstructive sleep apnea. And here's the scariest statistic for us in this room. 90% of those people remain undiagnosed in 2014. So despite all the notoriety, I think many of you are probably sitting here going like, gosh, I'm hearing so much about sleep in the last couple of years, I'm tired of hearing about it. 90% of people still aren't diagnosed. So part of our role, and part of why I'm so excited to be here with my fellow EOers today, you're my colleagues and friends, is that we have a public health obligation to our fellow citizens, our families, and so forth, our employees, to remember this. It is not uncommon for us at all to have a manager or owner of a business bring a valued employee in for evaluation because they're falling asleep at their desk, they've wrecked a vehicle. I just had somebody come in, the boss brought the patient fell asleep and drove a forklift through a giant pallet container and almost killed another employee. And this person was a valued employee, a good soul, good citizen, no drug or alcohol issues. The patient had a severe obstructive sleep apnea, undiagnosed. So what about diabetes and sleep? Adverse outcomes, you can see these. Daytime sleepiness is the one that's talked about the most, right? We hear that, oh, you're sleepy, you must have a sleep problem. But there are other things. What about cognitive function, your ability to think? When a person is sleep deprived, they don't think very well. That's the first thing that goes. Some of you, Tuesday night, might have stayed up late, right? There was a lot of activity on TV Tuesday night. People were watching the election. Folks were dragging yesterday because that's the first thing that we struggle with. Our thinking's not quite as sharp. I'm going to try to bring this up a little bit later, but think about those folks, and some people in this room probably have businesses where they travel long distances for business. 12 hours, 16 hours. They land, Without missing a beat, they start going to meetings, making very important decisions related to their business. When people have been up longer than 18 hours, they're impaired. When they've been up longer than 24 hours, they are more impaired than a person who's legally drunk. How often do our world leaders and business leaders get together in faraway places after having stayed up long periods of time to make decisions about billions of dollars, human lives, war and peace? It's really an interesting subject for conversation. Reduced quality of life, we're going to talk about the rest. So if you look at diabetes and sleep apnea, 80% of the public has diabetes. A lot of people, someone in this room certainly has diabetes, and I'm not trying to call them out, but statistically, it's so common. But you put them together, about 30% of people with diabetes alone have sleep apnea, even if you count for the weight. And we're going to talk about weight in a little bit. If you take high blood pressure with that, and I want to welcome, by the way, Brittany, who's our medical student here. She's a St. Louis girl from Chesterfield. She's working with us this month. But she can tell you, people with high blood pressure and diabetes, 60% of those people have undiagnosed obstructive sleep apnea, which is affecting their high blood pressure and their diabetes. You probably have family members who have this exact constellation of issues. It makes both of those things work. So what's a practical application? We've all had surgery in this room, I suspect. Either we've had it or know someone who's had it. If you're going to have surgery, one of the first things the surgeon and the anesthesiologist should do is assess your risk for having complications. That's their job, it's their call, it's their moral responsibility. This now is a fundamental issue of quality management. They have to assess every patient who comes in to see whether they have obstructive sleep apnea. So I'm going to tell you why that's important. One thing to look at is that what's been found out over time is the rate of death, generally a bad outcome, by the way. The rate of death postoperatively goes up in days 3 through 5 after surgery in this population of people. And it usually is sudden death. We're already starting to get legal cases brought to us because of this issue. Why is that? Well, one of the things we think, first of all, if you look at when these group of patients were studied, this is old data. The data's been reproduced, however, is that first of all, the majority of unexplained deaths occur at night within the 7 days post-surgery. Isn't that interesting? Big spike in people dying at night, unexplained. So why might that be? Well, first of all, there's heart issues that occur. And I think most of you are aware that most heart attacks, much higher proportion of heart attacks occur between 5 and 7 o'clock in the morning, whether you're post-operative or not. Something goes on during that period of time. I'm sure your parents probably told you this. I know mine did. Nothing good happens after midnight. In this particular case, there's some truth to that, right? So, then people will they'll have increased heart problems. Atrial fibrillation is where the top of your heart gets out of sync with the bottom of your heart and causes your heart to beat very rapidly. Most people don't tolerate that very well. You're probably seeing lots of advertisements now for some new blood thinner drugs. You guys seeing those? Xarelto and some other products on TV. Those drugs are made to be used for atrial fibrillation because you get strokes if you don't go on blood thinners. By the way, we are at Greensfeld where they've already started advertising for class action lawsuits for Xarelto, which I find quite entertaining. I think the drug's been out like 6 months. So, but what we think happens in this particular population is that right after you have surgery, so if any of you have had knee surgery, shoulder surgery, or surgery of an appendix, you remember those first couple nights, and you're just miserable. You don't sleep very well at all. You're disrupted, you sleep kind of crummy, and then pain medicine kicks in, and about 2 to 3 nights later, you sleep like the dead, right? You sleep very densely. What happens is REM rebound occurs. So what's REM sleep? This is a good jumping off part to talk about this briefly. So when you go to sleep, there are 5 stages of sleep. 1, 2, 3, and 4. And just rest assured, doctors, we're not very bright. So we kind of name things very simply. You guys usually come up with, especially lawyers, they come up with much better names. But 1, 2, 3, and 4, and then REM sleep, which is not a band, but stands for rapid eye movement, which was the original thing, discovered about 55 years ago, by the way. So this whole field's so new. So REM sleep is when 85% of your dreams occur. And this will come up a little bit later. I've got another slide for that. But that's what occurs in that time. It is the most physiologically unstable time of sleep, and it's about 25% of a normal night. Okay, so we got all that on the table. Any questions about that? It's kind of a cool thing to know. So when you're in that part of sleep, when you have been sleep deprived for a while, you know when it happens if you've been out, partying, whatever, had a lot of activity at home, kids have been keeping you up. When you go to sleep, you tend to get a lot more REM sleep. That's what occurs as you rebound from that. Days 3 through 5 after surgery, there's a huge spike in the amount of REM sleep that you get as you recover from those days of sleep deprivation post-operatively. That's where the increased death rate occurs. So if you have untreated sleep apnea, you're on pain medicine, which blunts your ability to respond to abnormalities. You have increased REM sleep, which makes you more unstable in the back of your throat. Boom, you have a cardiac or respiratory arrest. They call a code blue in the hospital, or they just find the person dead at home. So while sleep's really important, and I want to stress that it's important for our daily health, there are some big ramifications as well. Clinical exam. Why do people have to have sleep studies? Poor Brittany's heard me tell this already in a month very many times to patients. Is our hands are pretty darn good at what we do. We still only have a 60% ability to tell a patient whether they've got obstructive sleep apnea just by clinical exam. That's just not very good. That's not an acceptable rate. So we have to do some form of testing to assess that. Outpatient testing with conscious sedation. Why I put this in here? Many folks in EO now are getting to the age where they have to have colonoscopies. So they do conscious sedation. Frequently, folks will be told that you stop breathing or snore loudly, you should get a sleep test. This is the backup data, why they're telling you. So I hope if anybody has questions about that, I just wanted to make sure that you had a chance to see that. Why is this an issue too? If you're obese to boot, disastrous respiratory outcomes are due to intubation failure. So that's the ability to put the breathing tube down your throat, either before surgery or in an emergency. If you're obese and have these issues, it is very difficult. That alone can cause either brain damage or death. So again, we want to know these things in advance. What about heart disease? Sleep disordered breathing and heart failure. If we look at the crossover there between that group, 70 million people in our country, that's what we project. Heart failure, 7 million. One of the most common causes of health problems. It's also one of the biggest drivers of healthcare costs in our country today. I don't know how many of you have had heart problems over time, but chronic heart disease is a real issue, and there's a big crossover there. This is where I'm just going to skip this because it's a little too much physiology. Effectively, the issue is that this is a similar population of people. Now, this is no one in EO, by the way. I want to make sure we didn't put out a call for modeling. But the sleep disordered breathing people with congestive heart failure, they have very similar profiles. They tend to have high blood pressure. Dyslipidemia and metabolic syndrome is high cholesterol, diabetes, insulin resistant. They tend to have the inflammatory responses that go along with this. What other comorbidities? Look at drug-resistant high blood pressure. So if you're seeing your doctor or a family member seeing a doctor and they're having trouble controlling their blood pressure, more than 2/3 of those people have undiagnosed obstructive sleep apnea. And if you fix the sleep apnea, the blood pressure will be easier to control. It won't go to normal, but it'll allow the physician to control it much easier. Stroke, 60% of people have obstructive sleep apnea. Diabetes, we talked about that, congestive heart failure, and high blood pressure. Apnea means lack of breath in Greek. So you have a lack of breath when you're sleeping because your air pipe's obstructed. So that's what that means. Most people that we see will hold their breath for 20 to 30 seconds at a time. And I'm going to share with you a couple quick clinical stories and some other slides. But that the way you have an idea of what we're talking about. It helps to define terms. So people who have obstructive sleep apnea have an increased risk of cardiovascular disease, high blood pressure, insulin resistance, which puts them at high risk for developing diabetes, metabolic syndrome, high cholesterol. So the point of this study was if you took a group of patients that had these problems, could the treatment of obstructive sleep apnea with CPAP alter these risk factors? That's a reasonable question, right? That's effectively an EO business question. If I have a problem and I take care of the problem, will things get better? 32 patients. There's no test on this at the end. Basically, the closing of this is the patients had the same demographics. They were basically similar in height, weight, disease state, etc. They had sleep apnea, half of them were able to tolerate CPAP, so they were followed for 8 weeks. And this is what's fun, because many of us are at an age where we're monitoring our cholesterols. Anybody in here doing that? Come on, 3 people. All right, we'll take you for that. All right, so that's something we can measure. It's a measurable thing. So what happened? If you look at blood pressure, cholesterol, triglycerides, glucose, fasting insulin levels, the people who use CPAP for more than 4 hours for the next month or two, look what happened. I don't have a pointer, but if you look at the column that says follow-up, CPAP greater than 4 hours, systolic blood pressure, that's a very significant drop in blood pressure. Cholesterol, 27 points in 32 days. Triglycerides down, glucose down, insulin down. We're people who measure things. I know in our forum, we're always big on talking about our measurables. What is our goal setting? This is a study that did exactly that. So the physiology is variable, and that's one of the things we're going to move off sleep apnea now, because it'll wear you out. You guys hear enough about sleep apnea, right? But the bottom line is, why does, I knew we'll get this question, well, I have a friend or a family member, they got put on one of those machines and it didn't help them. The reason it didn't is not everybody is the same, and not everybody responds to that form of therapy, because the physiology is variable. There's 4 different types. That's why they need to be working with someone who does this. We actually take people off CPAP frequently because it isn't the correct therapy for their physiology, and there isn't a way usually to predict that in advance. So you have to be aware of it and adapt to it. Some people just need oxygen, some people need some other therapy, and I'll be happy to talk to anybody about that. Okay, so let's talk about pregnancy. And you can say your name however you want, Demi, Demi, whatever you want, but that's, of course, a very famous Vanity Fair cover, right? So, one of the things is, you don't have to be male and middle-aged to have sleep apnea. It affects children, teenagers, and pregnant women. Why are women a population at risk? I mean, half of us in this country are women, and it's important to understand that there's a certain degree of risk there. They have lifestyle issues that impact their sleep duration. Frequently, women are working. They get much of the childbearing responsibility. We're not totally sure why that is, actually. Women have an intrinsic sleep issue risk. They're at high risk for insomnia and sleep disturbance, and we're not sure why. They have a changing hormonal environment. By the way, men do as well. But women, their change in their hormones occur rather dramatically, where us as men, our changes occur over a period of 20, 30 years. One of the things you're seeing right now are all these testosterone replacement clinics. You all are aware of those? So one of the things that they're looking at in these clinics is they're going to ask you how you sleep. So it's an interesting thing. And when there's testosterone, if they have a low testosterone and they get treated, they tend to sleep better. So that's an important quality measure for them as well. It's an important outcome. Medical and psychiatric disorders, and then insomnia, sleep apnea, and restless leg. That's quite a slide, isn't it? We actually drew that in forum. So if you look at sleep disorders in pregnancy, I really enjoy, by the way, working with pregnant women in both asthma and sleep disorders. It's a great population. Patients do very well. You can really impact their lives. So this is just to show you, and we're not going to go through this. Don't get nervous. I see people are going to put their head down and start banging. All the things, the biological changes that are occurring in ladies when they're pregnant. It is a very significant physiologic issue. But so they have very high rates of leg movements, restless leg movements, irritation, pain in their legs. That's that symptom. You know who has restless leg? Most people here travel a lot, right? The person on the plane who can't wait to stand up and walk back and forth to the bathroom, most of those people have really bad restless leg syndrome. They can't wait to get up and walk around. So restless legs, they have disrupted sleep, they can't sleep on their backs, and now it appears that they have high rates of sleep apnea, which drives them to have high blood pressure and diabetes during the time of their pregnancy. So biological changes impacting sleep. We've talked about this, so their menstrual cycle. No one's ever heard that before, I'm sure. About half of pregnant women have difficulty getting a good night's sleep. Why that is, we need to talk to them about. It's usually varied. But it's important to address it because it starts to impact their well-being. And I'm going to show you how it also impacts the outcome on the baby, which we're very concerned about. Then there's perimenopausal women and postmenopausal women. Extremely difficult when people go through menopause and they start telling you that they're having difficulty sleeping, they are telling you the truth. It is very challenging on your sleep. First of all, most ladies have more hot flashes at night than during the day. So they're getting awakened at night. They're tired. It makes people irritable. It's a struggle. And with basically hormone replacement therapy, where they were giving people hormones, the ladies' hormones, since that has effectively been pulled away from the market due to the worry about cancer, it's caused that to be much worse. So it's just a good thing to be aware of. Sleep apnea in pregnancy, babies, and the outcome with that is they have, everybody here know what APGAR scores are? So when a baby's born, they'll say, okay, it's a measurement immediately at the time of birth and then a few minutes later of how well the baby is doing, breathing, color, all those sorts of things. And so the ladies who have either high rates of snoring or sleep apnea have lower scores, so the babies struggle more at birth. This is a visual slide we put in, kind of interesting. So this is an oxygen tracing. I'm sure you guys sit up at night and look at these. And if you look at the oxygen tracing, the bottom one is normal. See how this is kind of straight here? Your oxygen tracing really shouldn't vary. It should stay about 90% or higher. Look at that pregnant lady. This is while this lady was pregnant. Look what her oxygen level was doing. That is physiologically dangerous, even if in the best of times. But she also is carrying a baby in the womb. So that means the baby is being deprived of oxygen through that whole period as well. So it's not difficult to see that that could cause a problem for the baby in outcomes, and it does. Okay? Any questions on all that? It's all kind of heavy physiology, and I hope that wasn't too uninteresting to you, but it's really, I think, important. So this is insomnia. This is something that we all live through more than not. 10 to 16% of the general population. There have been more than 30 studies looking at people who have difficulty sleeping. How do we let's define insomnia? Difficulty getting to sleep, difficulty staying asleep with a daytime consequence. So if you say, hey, look, I have trouble getting to sleep, but I function great during the day, that doesn't meet the criteria. And that's assuming, though, that you're not drinking coffee to overcome it, by the way. Okay? So this is one of the most common things. If 8% of the population, 8% of the people you know have diabetes, significantly more than that are suffering with chronic insomnia, and you're probably unaware. So, and this is actually a business issue. Why? This population uses more health care, they have much higher rates of absenteeism, and they have higher rates of things like accidents and so forth. 65% of patients with major depressive disorder have an insomnia complaint. So you guys know here, Brittany's here, we really like to test medical students. Any clinical study where you can do something to medical students usually is a good study. So at Johns Hopkins, they did a study looking at medical students. And they took the medical school class, and they asked them all some questions. What they came down to is they divided them into good sleepers and bad sleepers. And they followed these people, they followed their medical history for 35 years. And after 35 years, they found something really important. The people that met top line there, that weren't good sleepers, had a 3.5-fold increase in the rates of developing depression over the course of their lifetime. So that is the seminal study, why we talk this conversation about why sleep is important for your health. It is clearly a risk factor for developing depression. And we're seeing that more and more. People are coming in, they're very worried about that, they're having trouble sleeping, they're having some psychiatric issues. Lastly, since we just left pregnancy, the lead article, and I just didn't have time to turn this into a slide because it came out Sunday, was there was new data that sleep deprivation in rats decreased their fertility in men. So where we go from there, I don't know, but anything having to do with sex and weight loss always plays well. So sleep and memory. Okay, what about memory? Probably one of the single biggest issues. Several things. First, sleep is dependent on memory consolidation. Why is that? There's been study after study that shows, and we just had this. In fact, Rich came to, and you weren't at our meeting for this lecture, but very famous speaker from Harvard gave his talk last week, 2 weekends ago at the Ritz. And you can look him up. He's done the TED Talks. His name's Stickle. But he'll show you the data that they'll teach you. You can be taught. Subjects can be taught. We can be taught. If we look at whatever the task is we're learning, and you try to reproduce it, if you measure the reproduction of that task before sleep and after sleep, you have your memory or ability to redo that task is dramatically increased. So it's clear that you need sleep for learning and memory. It's a really significant issue. And this speaks to the issue that we've been trying to talk to children about, and which is that don't stay up, pull all-nighters and things like that. You need to go to bed before your exam for memory consolidation. You'll do better on your exams the next day if you get a good night's sleep and consolidate that studying in your mind. You're able to do those tasks better. It's kind of an interesting thing. And I'd encourage you to look at that video if you have a chance. So this is a study out of France. And I figured this group's very keen on the work ethic in France. So there's strong evidence for a substantial and sustained decrease in sleep disturbances following retirement. So, somehow they got paid to do this study. They studied 15,000 workers at the French natural gas company. They were studied 7 years before and after retirement. Now, I know your first response is, I didn't know 15,000 people worked in France. Okay? But, interestingly, after retirement, their odds for sleeping better improved by 26% after retirement. So what were those issues? Well, these are the things they talked about. The psychological demands at work, physical and mental fatigue, depression, and being overweight. So the take home there is you're like, why is that important? Well, the thing is, for us, can we incorporate those healthy behaviors into our work life now versus waiting until after we retire? Stress reduction, physiologic reduction. So it's starting that idea of starting to incorporate healthy sleep into your day-to-day routines now. And you're starting to see that, and you're in the hotel industry. So one of the things we're seeing, we've been starting to do a little work in this area, but when you travel around, we're seeing it more internationally than in the US. But when you go in, they'll give you a pillow menu, right? That's a popular thing now. Some hotels give you a sleep package with blinders and a little CD with some nice music and all these things. Now, they're not doing this, just because they think it's cute. They're doing it because people are there to sleep. They're in a hotel. I mean, well, there may be other things going on, but that's not the subject of our conversation. But, yeah, but that's a real issue. So there's a business reason to be doing that, and that data is important. So, I think you're going to notice more of these things as you go forward. What about the immune system? We believe that the sleep-wake cycle does play a role in regulation of immunity. In fact, this is some of the best data, right? Let's go back to your moms and grandmas. They knew better. What's the first thing that happened when we were kids and we didn't get enough sleep? Especially if you're adolescents, right? You got sick, or you broke out with acne. Yeah? That's the reality. That's a direct function of your immune system. So, and we know this, if you look at the cells that take care of killing infection, they become dysfunctional when you're sleep deprived. So there's a biological basis for it. It's actually one of the more well-studied issues related to sleep. The other issue is that we're seeing so many of these patients every day. People with fibromyalgia, multiple sclerosis, myasthenia is a disorder where people, when they have a repetitive action, their muscles get weak. It's a fairly uncommon disorder. But the first two, and half of these people or more have some form of sleep disturbances. So the doctors that see lots of these patients make the vast majority of them get a sleep evaluation as part of their initial workup and making their overall health better. So, and everyone in this room, I suspect, knows somebody who has chronic pain, fibromyalgia, multiple sclerosis. They're very, very difficult disorders. So it's part of their overall plan to make them better. Why is it important? If you don't sleep well, if you're not getting enough sleep, you have insomnia, whatever it might be, your threshold for pain goes way down. So if your pain threshold goes down, what happens? You perceive pain much more severely. Their biggest problem is pain. So if we can just help them sleep better, frequently, the amount of pain medication they need can be diminished. And that's something that's good for all of us. even in AIDS and HIV disorders, we've seen that there's the relationship CD3 and CD8. Those are the cells in AIDS that are either diminished or dysfunctional. Poor sleep quality can even affect those. So I've tried to draw in all these various issues to let you see that this affects every aspect. And these are all people that you know. Lung fibrosis, which is a devastating disease. We have an adage in medicine. That adage is, there are things worse than cancer. This is one of them. Pulmonary fibrosis, up until a month ago, there was not a single drug to treat this disorder. Not one. 80% 5-year mortality. When you have pulmonary fibrosis, those poor patients, when you tell them they have that in the era of the internet, and they look that up on the internet, their blood drains out of their face when they come to see you. It's heartbreaking. Very high rates of sleep disturbance that can help their quality of life. So there just was a drug approved last month, which has some improvement in this population. So this is a really fun thing that I'd like you to put on your thinking hats. So think about, I took a little time earlier to talk to you about normal sleep. And we were with some EO folks. We went on like kind of a mini EO retreat last weekend. And one of the members that was there pulled me aside and said, my daughter's got narcolepsy. I really like narcolepsy. So, so I want to tell you a little bit about that. But I want you to think about this. So remember when we talked about normal sleep, so this is what we call a continuum. So normal's in the middle, and then we're going to talk about both ends. And the way to think about this is if you think about, we talked about like multiple sclerosis, or rheumatoid arthritis, or those sorts of things, that's when your immune system is too turned on. And then AIDS is when you don't have any immunity. If you think about, those are two ends of the same spectrum. Think about this, what I'm going to talk to you about, and that's what I'm describing to you with a different idea. Okay? So normal sleep's in the middle. 25% REM sleep. You're paralyzed in REM sleep. So in REM sleep, normally, okay, God was very smart, right? When you're in REM sleep, your brain looks awake. So like when we have the electrodes on your brain, we can't tell the difference between whether you're awake or whether you're asleep during REM sleep, except for one very important thing. You are completely and utterly paralyzed except for your breathing muscles and your eye muscles. Thus the name rapid eye movement sleep. So remember that. So that's when 85% of your dreams occur. So think about the physiology. You're paralyzed so you can't act out your dreams. Okay? So that's the physiology. Normal sleep. So what's narcolepsy? And if our technology was better today, I would have brought a video. No, I'm just kidding. So there's a thing called cataplexy. Okay? And cataplexy is what narcoleptics have. Brittany got to see this month already. So when these folks get emotional and they're awake, something happens. Has anyone here an Edgar Allan Poe fan? No? A lot of times there is. Jackie, of course. So I talk about Jackie. Jackie's doing great sleep work, by the way. So in Edgar Allan Poe, he wrote a book called a story called The Premature Burial. Premature Burial is a story written from the view of a young woman who becomes paralyzed while she's awake, can't move, and is buried alive. Poe almost certainly had narcolepsy, because that is the classic narcolepsy description. So in narcolepsy, you're awake, somebody makes you excited, go to YouTube and Google cataplexy. Okay? You'll see lots of videos of dogs and people having cataplexy. So they're awake. Usually it's a humor more than anger. So if someone tells you a funny joke, the person's standing there, the person starts to giggle, they collapse to the ground. But they're actually awake. They didn't pass out. So what little kids will sometimes tell you is that, yeah, I could see everybody running around, but I couldn't move. Or they were pushing me, but I couldn't move. You know, the paramedics came. They put me on a cart, but I couldn't move. But the people think that they're out. They're not out. Okay? So what that is, on that end of the spectrum, is sleep breaking out in wake. All right? REM sleep is breaking into wakefulness. And so their body's becoming paralyzed as if they were in REM sleep, but they're not asleep. All right? So that's a real important thing. Because we get people all the time that come in and say, "Oh, I got referred because my doctor says I have narcolepsy." The vast majority of them, by the way, do not. Only one in about 1,200 people in the United States has not the actual narcolepsy. But it's very commonly thought of. So that's the classic description. So that's REM sleep breaking out in wake. On the other extreme is a thing called REM behavior disorder. Anybody here heard this? You can't answer, but anybody else? Jackie? So what REM behavior disorder, the classic story is, it's not typically for our age group, okay? Usually it's older folks, so it's someone older, maybe 70, 80 years old. And we're going to use a man just because it's slightly more common in men, and you'll understand why. Who was in the war, been a good husband, good father, all of a sudden starts beating mom up in the middle of the night repeatedly. No knowledge whatsoever. Mortified, just embarrassed, horrified, right? And when you start talking to them, they have no knowledge of this. The spouse is bringing them in. They're usually thinking they're acting something out. They're in a firefight in Vietnam. They're in a battle in World War II. They're fighting someone with a knife in a street. Usually it's a similar dream each night. So what happens there? Remember what we talked about in REM sleep? You're supposed to be paralyzed. That interface in your brain, for some reason, it breaks down. And they start acting their dreams out. Very easily treated. Are there other questions as we go on? I mean, I'm doling this out there.
What
Yes.
is sleepwalking?
Okay, so sleepwalking is called, the technical term, by the way, we won't use it again, is somnambulism. It's a great Scrabble word, by the way. So,
Can you spell that?
I know Rich, you're a smart guy. So, sleepwalking happens when people are sometimes, first of all, it's not, normal's the wrong word, but it's not uncommon. It typically goes away as people get older. Usually it's related to priming. So most people have it if they're overtired, right? If you have young children and they're overtired and they tend to be sleepwalkers, you'll tend to notice they do it more if they're not kept on their strict schedule. It usually will become extinguished as you get older. Safety is the number one concern. So if a person has sleepwalking or they have REM behavior disorder, if they're really walkers, you have to make sure that their rooms are safe. They can't open their locks. If they're of driving age, the car keys have to be locked in a place that they can't unlock. I mean, these are really serious issues. Their bedrooms, the windows have to be done correctly if they're on the second floor so they can't open them. People have become paralyzed, had brain injuries, been killed because the safety issues weren't taken. But what it is the person's, their brain is triggering an awakening while they're in slow wave sleep, and they wander around, but they are completely unaware. And then, but they're not acting anything out. If you wake up a sleepwalker, they don't have any idea. So it's a really interesting thing. But that's other questions along those. I love these. Mike.
What about, I have kids that talk in their sleep, and my wife says I laugh in my sleep. So what stage of sleep is that, or
Yeah,
what's happening?
more than likely you're in what we call, that's usually slow wave sleep, and you are really laughing. Something in your brain is making you laugh. It is normal, as long as it's not bothering you. There really isn't anything to do about it. Medication is only going to give you side effects, probably going to be relatively ineffective, but it is normal. I mean, sleep is an active, exciting period of time. I mean, if you look back, old medical textbooks are really cool. I have a pathetic life, right? But old textbooks are really cool because if you look back into like 1920, 1930, if you read the few sentences they have about sleep, a third of our life, all it says is sleep is lack of wake. I rest my case.
If they're talking during, kids, it's almost like I can carry on a conversation with them.
But it's not real, and they don't know what they're telling you. So,
okay.
if they're telling you bad stuff, don't hold it against them too much.
All right.
Okay, they may be telling you the truth, but not necessarily.
And what causes that? Is that
What they're having these arousals during delta sleep. That's what the question was. That's the big chunk of sleep. That's when especially children have very high rates. It's deep sleep, but it's when the brain's really jumbled up. And so we say kids have high delta drivers. That's why if you look at young people's sleep, they have lots of delta sleep. That's why they're constantly falling asleep, and when you wake them up, they're confused. The Did you ever get woken up and you could have someone said, you know, Ricky, I called you. You had a perfectly lucid conversation on the phone. You told me exactly what nutrition to eat, and you couldn't have been nicer. And they see you the next day and they go, Ricky, it was great talking to you the other night. And you're like, really? No recollection. That's when you get woken up during REM sleep. When you get woken up during delta sleep, confused, giggling, not making sense, that sort of thing. It's very well defined. Jackie, and then.
So, Sarah, these things are affecting the amount of REM sleep. Should they be treated for that?
Yeah, so we call parasomnias, and I don't know if I have. There you go, Rick, somnambulism. So parasomnias, or we call them things that go bump in the night. One of the key aspects of these sorts of things, people who act out dreams, walk, have night terrors, the person doing that is usually not sleepy or tired. So it doesn't have any effect on their overall, daytime function, except for safety. If they get hurt.
It's not obstructive, so it doesn't
No,
do anything with it.
no, not at all. But it's very upsetting if you're not the person. So, I'll share with you, this is, again, what did we talk about? Weight and sex, right? So, REM behavior disorder, have you guys heard about the sleep-sex syndrome? Right, so the person acting out their dream, we talked a little bit about how the person might be in the war, this or that. One of the behaviors that can be acted out, and I want to really stress in a very sensitive way, the person doing the action does not know it. It has no relationship whatsoever to marital discord. It doesn't even have any relationship to their sex life, sexual repression, anything, okay? But their action that they act out is sometimes acting as if they're doing the sex act. Sometimes they will do some self-pleasuring. We had a couple who came in because the husband was standing in the middle of the bed doing that regularly, had no knowledge at all. So one, the treatment's the same. We treat them very easily, but then we have to... Well, no, you have to... The medicine.
Oh my God.
Sorry, Juliet.
Nothing to do with it.
No. It's called a continuation. Yeah.
Got it.
So, the medicines, the treatment's the same, but you have to counsel the couple because they'll have marital problems related to this, as you would imagine. But that's the same sort of thing. But these people are not tired at all. So a lot of times this is going on in households for months or years, and people don't want to talk about it because they think there's something wrong. When it's just nothing's wrong at all. So that's an extreme case of this. But when you hear about this, the other thing you'll hear about, if you haven't ever seen the medical legal defense for murder, you guys have gotten to see this. You remember he murdered Susie when he was asleep, right? This is the basis for that defense, which, by the way, is usually bogus. Okay? But what we just talked about is the basis that they use for that defense. That, he was asleep, so he did this, or she did this while asleep. That usually it hasn't worked very well. Let's just leave it at that. Yeah?
Probably speak for all of us in this room. We all have different levels of stress throughout the day with all the obligations we might have. And I can tell that I'll wake up at 3 in the morning and consistently wake up at 3 in the morning and can't fall back asleep for a couple hours after that. Is there anything that I can do? Is it jotting down what I need to do the next day before?
Yeah, so that's really a common question. And I'm glad you're asking because I want to make sure we're answering stuff that's practical for you as well. And this timing's perfect. We're right at the end. So that's one of the single most common things we get. 2 to 3 a.m. waking up. So there's a couple things going on. One, it usually is stress. In men, we have a suspicion that sometimes it could be related to subtle change in hormones. I'm not advocating that you get that checked. It's just a suspicion. Part of it is when you wake up, first of all, it is normal to wake up. Every 90 minutes, we cycle through all the phases of sleep, and then we arouse. When we study you in the lab, people arouse. They look around. They're frequently not aware. Think about when we were cavemen and women and lived in the jungle. We were the apex predator, except for maybe lions and tigers. We theoretically wake up, make sure you're safe, go right back to bed. However, sometimes as we get older, we start to wake up at 2 or 3 in the morning. We look around, and then we've got just enough sleep that we start saying, "Oh golly, I've got a big proposal tomorrow. this or that's going on with my family. Once that starts, boom, you're off to the races, right? So a couple things. One, preventive. The first thing we tell people is when they get up in the middle of the night, if you can't go back to bed, get out of bed, sit quietly. Don't turn TV on. Don't get on your computer or your cell phone under any circumstance if you can avoid it. Okay, and I'm going to explain why in a second. Okay, and just be calm. If you want to read something that's not very exciting, read it with kind of a dim light. And do some stress reduction. So that's a good time. If you're a prayerful or spiritual person, that's a good time to sort of use that to mellow down. And then as you get fatigued again, get back in bed. That'll do several things. One, it's probably a one-off. Okay? So if you do that, you won't habituate. But if you get on your computer and you get on your cell phone, first of all, they have high levels of light. Light is one of the most stimulating things to tell your brain to be awake. Your brain is amazing. If you do that one night, 3 o'clock the next morning, you're going to wake up and it's time to get on my computer and check my emails. It's almost guaranteed. So that's one strategy. The other strategy is if it is persistent, then we have a sleep behavior person that works with people frequently, and in a few visits, we can teach them the skills to sort of calm themselves down into sleep. Sleep is like sex for a man. How so, you say? If you think about it, you can't do it. Okay? So what happens is when we wake up during the night, all right, whether you're a man or a woman, you immediately go, crap, it's 3 in the morning. I got to be in bed. I got to be asleep. Boom, you're done. So we have to actually do the opposite of that, which is have the skill set to wind things back down and ease back into sleep. It is a learned function. What we tell people who have trouble getting to sleep or staying asleep, people in here play golf? Right? If you're a golfer, what happens when someone changes your swing? It is miserable, isn't it? Because you have a new muscle memory. Changing your sleep is exactly like that. When we start teaching people how to do these things, at first it's a bit uncomfortable, but then as they work through it, things get a lot better. But that's exactly right. And your suggestion, we have people call a worry journal. And if they wake up and they have lots of stuff on their mind, or they can't get to sleep because of that, we'll sometimes have them do a journal. Believe it or not, you write all that stuff down, you leave it there. It's funny, the brain is amazing. We also try to find out what is it that they like to do that makes them calm. Whatever that activity is. So 2 things. One, in EO Nepal, they had Matthew Ricard there. Anybody here know who Matthew Ricard is? He's the son of a famous French philosopher, and he was the man, and I think his mother was like a poet. He became a Buddhist monk who specializes in meditation, the so-called happiest man in the world, which I'll share that email with you later. But he's also a neuroscientist. And when you look at very specialized brain studies, the parts of the brain for meditation that light up are the best parts of the brain for happiness and sleep. And we use that exact work when we work with our sleep patients. So to give you an extreme example, we had a patient not long ago. We're trying to figure out what we could do to help him get to sleep. And this guy was kind of a mellow guy. Well, he divulged to us that he was a bass player in a rock band. You're like, okay. The thing that relaxed, first of all, most bass players look asleep when they're playing the guitar anyway. But what he divulged to us was that was the one thing in his life that relaxed him and made him mellow. So we have him play the bass guitar for 20 minutes before he goes to bed every night. Makes him happy. Makes him relaxed. We have priests that we have him do the rosary and things like that. So anyway, that is the single most common question we get, and it's the most common cocktail party question we get. So I appreciate that. Yes, Cheryl?
I had 2 things. One, just an experience to share on what Joe said, because that happens to me a lot, and I turned the light off on my alarm clock so I can't see the time. So when I wake up, I would usually look at the clock, and then I would get frustrated that I was awake at 2 or 3, and that would really agitate me and then make me be more awake, and it's really helped me a ton to not be able to see what time it is.
And I think that's a really good, thank you for sharing that. That's a very important and common source of advice we give folks. Actually, you can buy clocks now that the face will go dark, so that so that just to give you an idea of how important that is. And that, yeah, Michael.
My thought if I wake up at 2 or 3, I can't do a damn thing about it right now, so let it go. And that just helps me turn it off.
Everyone's, yeah, they're,
That's the same thing. I look at it and I see it's 3 o'clock in the morning and my brain goes,
Uh-oh.
4 more hours of sleep.
we love guys like you. Got you, we got you.
So when you're talking about like brain activity and light and things like that, obviously, what happens when people watch television all night long while they sleep, or they watch television as they go into sleep?
Yeah, so we typically tell people that's not the right strategy exactly for the light and the activity, right? If you're watching Rambo as you go to sleep, that's probably not going to work out, okay? So now, this is for people that have that susceptibility. Some people watch TV and they can get in bed and go right to sleep, but it's a combination. Light, if you look at the light from a desktop computer especially, very high rates of lux, measurements of light. It is one of the most stimulating things for wakefulness you can have. So if you're going to watch TV before bed, you should try to be out of bed. So if any of you have been in our sleep lab, we have the TVs over the headboard. So you actually cannot watch TV in bed. Okay, so that's number one. Get out of bed. If that's your wind down, if that makes you happy, then watch TV, but don't be in your bed itself. The other thing is, try to watch things that don't make you either excited or angry. So, if there's something you want to watch, then it's more the calming. But if you're going to lay in bed and watch TV, that usually will that'll become a habit for you. Probably not the best habit. And if you leave it on all night, and I guess now I have to use Jimmy Kimmel, I used to use Leno. But if you go to bed to Jimmy Kimmel's monologue, the problem is when you wake up at 3 in the morning like Joe, Jimmy Kimmel's not on, at least not in my house. So if that's your cue to go to sleep, you can't. So you don't want that TV activity to be your cue. The brain is very much about habits and patterns. You got to be careful which ones you set. Yeah, Mike?
What are the negative effects of watching a show on your computer? Because I have a couple kids that say, I just always watch a movie or a show on my computer to go to bed. And I just think that that's not healthy. And
Yeah.
so what can I tell them? Hey, guys.
The issue is that's going to become their habit, and what you want habits for sleep initiation that are transferable. So if they go camping or they go somewhere where they don't have their computer, number one, they're not going to have that. Number two, that the light from technology is very disruptive, and they need to get it out of their bedrooms anyway. It is an epidemic right now, and some of you may have seen these interviews we've done, but texting, cell phones, iPads in the bedroom of children is an epidemic. We did a survey in a rural junior high here in Missouri, 700 kids. 60 to 70% of those kids in junior high are sleeping with cell phones in their beds. Text messages coming in all night long. So developing those habits is difficult as it is. They need a non-technology wind down. How they choose to watch content, that's sort of a decision between you and them. But on the computer is going to be very stimulating.
And so does that mean, does that mean that they won't sleep as deeply or as fully? Or is it going to just take longer to get to sleep?
One, it's going to take longer to get to sleep. Two, when they wake up during the night, which is normal, they'll frequently have difficulty getting to sleep or develop those habits and patterns. And at that age, are your kids, are they?
19, 21.
Yeah, so one of the problems at that age anyway is they have a tendency to go to sleep later and get up later. That's biology. It is going to exacerbate that. And so we see those kids, and this is not uncommon, is their parents bring them to us from their colleges and say, Susie's going to bed at 3 in the morning, missing all her morning classes and getting up at noon. And so that's really a problem.
Okay, so I read this wrong, but I read that these things, most computers have a short blue wavelength, and there's certain receptors in your eyes that make you awake. It actually distorts the melatonin, and it causes that interference. So I switched to reading a Kindle with a little book light on there, and I now sleep better, because I was reading this every night.
So this is a great business issue too, since this is EO, right? So Rich is talking about blue light, because blue light is the things in the blue light spectrum wake you up. So guess what's happening? This is happening more in Canada and China, but it's coming here. On the night shift, they're starting to give people blue light blockers to wear after 3 to 4 in the morning, so that when they go home, they will have had that blue spectrum light blocked, and they'll get to sleep more easily. Now, in China, reportedly, they're putting in contact or lenses for like cataracts and stuff, in some people who block blue light, so that people sleep better. I don't see that coming here anytime soon. I mean, there's a whole set of issues related to that report, but Rich's idea on blue lights is actually a key issue that's getting more and more traction. Yes.
I have two questions. The first is, can you sleep too much? Because I notice sometimes if I sleep longer than my typical, I wake up groggy. The second is, can you catch up on sleep?
Thank you. This is the stuff that we want to get out on the table. One, the idea of sleeping too long, usually what's happening is you're not probably getting enough sleep normally, and then you sleep a little bit longer. That causes, you have two mechanisms of how you sleep and how you're refreshed, okay? The one mechanism is basically, if you think about a cup of coffee, you fill that cup of coffee up by sleeping all night, and all day long, you're pouring that out. When it gets to be empty, you're sleepy and you need to sleep again, okay? So we call that homeostasis. The other one is your circadian rhythm, which is like an oscilloscope. 2 peaks of sleepiness, 2 peaks of wakefulness. That's the source of jet lag, okay? Both of those systems are running simultaneously all day long. You guys with me so far? So, in the morning, if you get up at the same time every day, then those systems are lined up. They're lined up perfectly from light, from work, all those things, okay? And they stay lined up the rest of the day, because our body's internal time clock, believe it or not, is like 24 and a half hours. So you constantly have to line it up. When you sleep, quote, too long, sometimes you get into a phase where the oscilloscope one, the circadian rhythm, is a little out of line. So you're kind of waking up when your body's internal clock is telling you to be a little sleepy, right? There's a reason the siesta exists. The siesta is biologically correct. Mid-afternoon, we all have a biological dip in our sleep clock. It is the second peak of sleepiness during the day. The other peak's at 3 to 5 in the morning, which is why so many auto accidents happen then. Okay? So that's one way. The other thing is there is a thing called sleep inertia, where you actually, when you get up, you have this sort of carryover sleepiness effect. Okay? So the issue there is probably that you're not sleeping too much, is that you're not sleeping, you're out of your habit. You're out of your normal sleep habit. The other, catching up. So, and I will come right there. The other catch-up issue, so we typically tell people you can't sleep deprive yourself all week and then try to catch up on the weekend. That actually will make you more prone for a lot of other sleep issues like insomnia and other difficulties. Sometimes it's just life. You know, we have folks that are, they come in, they're struggling to make ends meet, they got little kids, they're working 2 or 3 jobs. We try to adapt to what the person's personal needs are, but by and large, you're better off to have a more stable sleep schedule 7 days a week than really sleep deprive yourself and then sleep long on the weekends. That usually isn't what we recommend for a variety of reasons, like I just explained. In an occasional situation, it's okay, but you're better off to stretch it out. Most people in the United States today are sleep deprived. The vast majority. Yes, sir.
Along those lines, and since this is EO and most EOs I've met at cocktail hour, or happy hour. What are the studies, what's the science behind the impact of drinking, especially, I know a guy that once in a while drinks a little too much, and then no matter how much he sleeps, he still can't recover, and not just from the queasiness and hangover side, but just feeling sleepy for 12 straight hours.
And then the person probably wakes up really early, don't they?
No, this particular person, if his kids allow him to, will sleep well into the afternoon.
Okay. So he probably has something else as
on
well.
a given Sunday.
Let's talk about alcohols. This is a very important topic. So, one, alcohol becomes a neurotoxin after about 4 hours. Okay. So initially, alcohol is very sedating. Okay, we're all kind of somewhat aware of that. So you drink alcohol, and after a little while, you start saying, oh man, I've had enough to drink, I'm starting to feel a little bit sleepy. But here's the problem. You go to sleep, and then about 4 hours later, your brain becomes irritated as it becomes neurotoxic, and you wake up. So think about when you were maybe in undergrad, or maybe in your 20s when you used to maybe drink a little more than you do now, and you wake up in the morning. This is the classic case, or you get up, be like 6 or 7 in the morning, you go like, I don't really want to be up now. Why am I up, you know? Well, that's why. That's typically why you wake up. And so that also exacerbates the hangover. So the other thing, and for those of you, I think it was in our Huffington Post blog this week, when people use sleep or alcohol as a medicine to go to sleep, not only is it a bad sleep medicine because of what we just talked about, but you also have to dose escalate. Meaning, to keep getting the sedation effect, you got to drink more. So people that start doing that, they'll, high risk for alcoholism and drug abuse, and they're using huge amounts of alcohol to get to sleep. Well, weight control becomes a problem then as well. So there are a whole variety of issues as it relates to alcohol and sleep, and not really any of them are very good. Okay? There may be something else going on if someone's sleeping like that. There may be some secondary issues as well. And it's one of the issues we tell people about travel. You know, really light on the alcohol on long haul flights, light on food, get a light meal and get right to bed. And I can give you guys we can talk about jet lag as much as you want. I love it. We've done some stuff with some EOers from other cities to help them. We've Skyped with them to help them with travel. Yeah.
Just a simple question. Kids, like you said, maybe even early kids, starting school, kindergarten, pre-adolescent, and then adults. Is there an amount of time that's suggested? I'm sure.
Yeah, there is. Yeah, there is. First of all, it's based on large populations, right? So let's talk about adults first. It's still a bell-shaped curve. So remember grades. No one in here ever was at the peak because that's like the C students, right? Everyone here, of course, is an A+ student, I'm sure. But that peak of the curve is what we view the amount of average sleep people need. About 7 hours and 45 minutes statistically. The amount of sleep you need was determined the night that your parents conceived you. It is in your genetic code, and there's nothing we can do to change it.
So you could be a functional person with 5 hours.
Absolutely. But let me tell you, based on the people I see in the office, you'd think that was about 90% of our population. It's statistically less than 1% of people can exist on 6 hours of sleep or less. So, and believe it or not, there's 1% of people who need 10 hours or more. Think about that. That's losing the biological. That's really not a great thing to get in your gene pool, you know?
Yeah, it's probably the same thing that you guys better, but there's a lot of nights, most nights, where I can remember my dreams and it's like I'm watching a movie for hours and then wake up and still really tired. Is there any ways to combat that? Where is that the lucid dreaming that he's talking about?
Yeah, so here's the issue. The lucid dreaming probably isn't what's making you sleep. Unless it's dreaming that's upsetting you and you're getting up. So what more than likely, frequently what we see with that is that you're having a lot of lucid dreaming because you're not getting enough sleep normally. And so you're having that REM rebound and you're dreaming a lot because you're sleep deprived. And so the issue there, sometimes what we do, we have a little wristwatch, but it's not a watch. It's actually a motion detector. We put it on people for a week or two. We can actually tell how much sleep you're getting night to night to night to night. And we can tell you if you're sleep deprived based on the data, not based on us doing any brainwave studies, but it's a helpful exercise. I mean, we've done them for most of the media people here in town, the morning show people on radio and TV. It is absolutely shocking how little sleep those people are getting. When we show it to them, they're all like mortified, but it's the worst job there could be. Anthony.
One of my daughters went through a phase where in the middle of the night she would start screaming like her limbs were being sawed off. And she's basically, we can't wake her up. Like all I can do is get in bed and hold her. And
how long did it last?
Sometimes it was 20, 30 minutes, sometimes it was 10 minutes, but really bizarre. It lasted about 6 months and just...
How old was she?
3 or 4.
So that is a wonderful description of sleep terrors. Brittany, listen to that. That is sleep terrors. Absolutely wonderful. That is a textbook. You open the textbook, read sleep terrors, and you just described it. It is nothing to worry about.
Yeah.
It's frightening child has absolutely no recollection at all, doesn't hurt them. They're not tired. She wasn't tired, I
Is it a
assume.
precursor for anything?
No,
later
it is
in life
not.
to worry about?
It's no. There's nothing for you to worry about. It is absolutely nothing. But it is frightening as all heck. Yeah, it is. That's a classical description of sleep terrors. Thank you for sharing that.
Guys, can we do one more question? And then Joe, if you have a couple of minutes maybe
Okay.
to engage some folks one-on-one, if you have
Yeah,
time,
happy to
that'd
do
be
it.
awesome. But I just want to be sensitive to everybody's time, so.
Yeah, I hope I didn't ramble off. I'm sorry.
Just a couple. Great today. A lot of great stuff here from just executive level to kids, etc. But effects on growth in kids is one question I have. And then my youngest son is ADD, so he takes ADD medicine.
Okay.
So how do we cope with that? Because we know there's a fine line if he's going to stay up until X time. When do we stop studying?
How old's the young man?
8.
So a couple things. I thank you so much for that question because we were talking earlier. I didn't want ADD to go by. Okay. So let me address that first. First of all, I'm agnostic about medication. So when I'm going to give you this information, it's not because I'm trying to sway you. But there are several studies now that are very clear that up to 25% of children diagnosed with ADD really have sleep apnea or another sleep disorder, and they should not be put on medication for ADD right away. So if there's anything, as far as your families, you take out of here, please, I urge you to consider that. Okay? Because children, when you study children that are sleepy or that have ADD, okay, their symptoms are identical word for word. Can't tell them apart. Now, I'm not implying that's your son. This is for the whole group, but it is. We're really passionate about this because if you have a child who's been told they have ADD, they look like a normal little kid, okay, running around, active, bouncing off the walls, and what they really have is sleep apnea that's undiagnosed, and they take their tonsils out, they're cured. Isn't that better than being on a lifetime Ritalin? And it's more physiologically proper. So I'm just throwing that out to you for your consideration because we're just really passionate about that from a public health standpoint. So one, that's something to think about. On growth, yes. So there is some data to suggest that if kids who sleep the proper amount, do things right, do grow better. Based on that information, I probably slept like 4 hours a night.
Well, and then the ADD medicine is a growth hormone suppressant.
Exactly. So that's why it would be really helpful. So I don't know if that was part of the evaluation between you and your physician, but it is the easiest thing to get checked out and well worth it. As we would say in business, it's low-hanging fruit. They get a sleep test, it's positive. If that's the deal, you get their tonsils out, boom, no medicine. So it's something to think about. And I'd be happy, I'll help you facilitate that as much as you want. We're all important, but kids are really important. Awesome. I hope this helps. I want to acknowledge, by the way, that Jackie Demko is here, who not only is she an awesome human being, but we send patients to her for the sleep oral appliances. It's one of the treatments for sleep apnea. So I want to make sure, first of all, I'm honored that she's here, but within EO, we have a lot of resources to help each other, and just wanted to share that. Thanks so much for allowing me.